Bismillahirrahmanirrahim. This is Professor Khursheed Khan. I'm Professor of Medicine and Endocrinology at Fatima Memorial Medical and Dental College and President of Pakistan Endocrine Society. I'm very thankful to Professor Tafazzal for inviting me to speak on this prestigious forum on this RheumaCon 2021 organized by Sheikh Zayed Hospital and Medical College. So what I'm going to talk about is osteoporosis. How does it happen? What is the role of calcium and vitamin D in pathogenesis of this disease, and what can be done to prevent it, and how we can treat this very widespread problem, especially among our elderly population and females. So the definition of osteoporosis. Osteoporosis is characterized by the low bone mass and microarchitectural disruption leading to skeletal fragility, and that results in decreased bone strength and increased risk of fractures. So if you notice in the definition, there are two parts to it. There's a low bone mass, and not only there's a low bone mass, but there is a disruption in the microarchitecture of the bone. And that, of course, puts these patients at much higher risk for fractures. Now, what causes this? Obviously, the decreased bone mass and increased fragility can occur because of either the failure to achieve the optimal peak bone mass or because of increased bone resorption by the decreased bone formation. The peak bone mass, we all know, maximum bone mass is achieved by 25 to 30 years of age, and that is determined by many factors. Genetic factors are very important in here. Race, we know the blacks, they have higher bone mineral density compared with whites. Asians, they have higher bone mineral density compared with whites as well. Gender, men tend to have higher bone mineral density by about 8 to 18% compared with women. Nutritional status, optimum intake of calcium plays a very vital role in attaining optimum bone mineral density at a younger age. Physical activity plays a major role. Tobacco use, it has a negative effect on that. It leads to decreased bone production and decreased peak bone mass, and later on in life leads to osteoporosis as well. Different hormonal deficiencies and medical comorbidities that also hinder the attainment of peak bone mass in young people. So now the total bone mineral content of any individual at any stage of life, it depends on what was the peak bone mass in that patient. In young adults, remember this, during the formation of the bone, in formation of the bone, there's always new bone being formed, and there's always some bone being resorbed. That's like maintenance of the bone, I call this. In young adults, the amount of new bone formed by osteoblast is equal to the amount resolved by osteoclast. As the old years of our age approach, in females in menopausal years, bone remodeling occurs at a higher rate than in premenopause area. So rate of resorption is more than the bone formation. There's a net bone loss, and then there's increased risk for fractures. Now, what leads to all this? I think we're going to discuss this in coming slides. How does this happen? But before we go on to that, remember, patients can have primary osteoporosis, where osteoporosis in women with the natural menopause and in older women with low sex hormones. But then there's a secondary osteoporosis which can present at a much younger age. Usually there tends to be an underlying cause for secondary osteoporosis. Anytime you see a patient with osteoporosis who is not like your usual age group for osteoporosis patient, well, we need to look for underlying cause and see what underlying factors can cause osteoporosis. This is a huge list of underlying causes, starting from drugs, which include steroids, anti-seizure medication, and many others, endocrine disorders, starting from Cushing's to acromegaly to hypogonadism, and so many. GI diseases, alcohol-related liver disease, celiac disease in males is a factor there as well. Marrow-related disorders, amyloidosis, leukemias, organ transplantation, And then there are other miscellaneous causes, ankylosing spondylitis, COPD, or some genetic factors like hypophosphatasia. So there's a huge list of differential diagnoses. When you see osteoporosis in a younger age group where we should not be seeing osteoporosis, we need to go through all these differential diagnoses, and then proper workup needs to be done to find out what is the underlying cause, because these are the patients where we want to address their underlying cause. Now, what happens there? Why we have osteoporosis? I think, let me go back to the very basic question of physiology in these patients, which is interplay of vitamin D and PTH in bone metabolism. We all know the important target, bone is an important target when it comes to actions of vitamin D along with other tissues. So where are vitamin D receptors within the bone? The osteoblast have those receptors, not the osteoclast. But so that means any signal which vitamin D gives for any kind of activity within the bone is through the osteoblast, and then those osteoblasts produce some paracrine hormones, which we will come to that in coming slides, and then activate the osteoclast as well. So 125 dihydroxy vitamin D acts on osteoblasts, which produce a paracrine signal that activates osteoclast to resolve calcium from the bone matrix. And the same 125 dihydroxy cholecalciferol also stimulates osteocytic osteolysis as well, which is very quick, rapid absorption of bone, leading to more calcium within the bloodstream. And the one part we said, yes, vitamin D stimulates osteoblast to produce paracrine hormones to activate osteoclast to cause bone resorption. But the second part of vitamin D action in the bone is very important, which is mineralization of the bone. So proper mineralization of the bone is stimulated by vitamin D also. Active osteoblasts synthesize and extrude collagen. So collagen fibrils form areas of organic matrix called osteoid. Calcium phosphate is deposited in the osteoid and becomes mineralized under the effect of vitamin D. So mineralization is a combination of calcium phosphate, hydroxy, and hydroxyapatite crystals, which get laid on that collagen fibrils on that osteoid within the bone. So in the absence of vitamin D, excess osteoid accumulates, and what happens is then collagen synthesis gets repressed, the mineralization of that osteoid does not happen, and that results in the form of bone disease, which we call rickets. So vitamin D is not only important in facilitating osteoclast through osteoblast, but vitamin D is also very crucial in helping the bone to get mineralized properly. So mineralization requires adequate calcium and phosphate on board. Is dependent on vitamin D. Alkaline phosphatase and osteocalcin play roles in bone formation, and their plasma levels are indicative of osteoblast activity of that particular subject. Now, where comes the PTH hormone in this whole interplay of things? So the overall action of PTH to increase the plasma calcium level and decrease phosphate level. PTH acts directly on the bones to stimulate calcium resorption and kidneys to stimulate calcium reabsorption in the distal tubules of the kidney and to inhibit reabsorption of phosphate, thereby stimulating its excretion. Now, the PTH has a very facilitative role in activity of osteoclast. It puts osteoclast in a simple words, I would say, on a turbo speed to cause osteoclastic activity within the bone. So it has permissive action on osteoclast, and which leads to resorption of the bone as well, and really causes the release of calcium from the bone. PTH also acts directly on intestines by stimulating 125 hydroxy cholecalciferol synthesis as well. So it's a mix of calcium, phosphate, vitamin D, and PTH, which basically regulate the osteoblastic activity and osteoclastic activity and mineralization and demineralization of the bone in all subjects. So if we go at the molecular level, what is important when it comes to the osteoclastic activity? I'm sure most of you are familiar with the rank receptors, and rank ligand pathway that is very essential for osteoclastic activity. Remember I said vitamin D stimulates osteoblasts to produce paracrine hormones, and the PTH in association with paracrine hormones activates osteoclast to cause resorption of the bone. So that resorption of the bone is mediated by the rank receptors present on the surface of osteoclast. So if you look at these hook-shaped structures on the surface of osteoclast, these are the ones which kind of stimulate the formation of stimulates the formation of activated osteoclast and leads to the resorption of the bone, leads to the increased osteoclastic activity within the bone. Now, the nature has given another system to counter these as well. These rank receptors and then these rankle ligand. You see these hook shapes are rank, and when these rankle ligands, which are these star-shaped structures which get hooked into there and activate this whole thing. Now, to counter this whole action, to keep things in balance, the nature has another protein within the system which can neutralize the rankle ligand. So body produces a protein called osteoprotegerin. So osteoprotegerin, if you look at these green disc-shaped proteins, what they come in and they wedge within the rankle. So the rankle cannot get connected to the rank receptors there to activate the osteoclast. So the activation of the osteoclast does not happen. So it's a combination of rankle and osteoprotegerin action, which creates a balance between resorption of the bone and formation of the bone. And this is just to show you how the osteoclastic and osteoblastic activity goes, and look at all these hormones which I showed on this slide. I'm sorry, it's a very busy slide, but it just to highlight you how important all these factors in kind of how many factors are involved when it comes to resorption and formation of the bone. Resorption of the bone by osteoclast typically happens within about 20 days, you can say 3 weeks time, and the formation of the bone usually takes about 100 days to happen. And look, here it is. So osteoblasts, they get stimulated by vitamin D under the conducive environment of parathyroid hormone present as well, and that all these things they send those paracrine signals, which I earlier said, interleukin 1, interleukin 6, colony stimulating factors, TNF alpha, TG beta, all these factors, they go to the osteoclast and stimulate osteoclasts to cause osteoclastic activity there. So if we talk about females, what happens is, this is a one single bone forming unit. If you look at this, normally bone is being resorbed and being replaced by some bone, but anytime there's a remodeling of the bone, we tend to lose a bit more bone and create a little less bone than what was lost. But as time goes on, especially in females after menopause, when this facilitative action of estrogen is not on board, in these patients, the osteoblastic activity, in these patients, the formation of bone is significantly reduced. So if you look at this at menopause, this is the bone loss. This is significant bone loss. If we follow this curve all the way down to the lower levels after the menopause in females. So estrogen deprivation, what does it cause? It causes increased production of osteoclastogenetic factors, which earlier in the previous slide I said they were interleukin 6, 1 and 2, and TNF by osteoblast, and then it decreases the production of osteoprotegerin. Remember I said osteoprotegerin inhibits, it blocks the action of rankle so that there could be a balance between resorption and formation of bone. So decreased level of osteoprotegerin because of estrogen deprivation, and increased receptor activators of nuclear factor kappa B ligand, which is rankle. So that deadly combination leads to more osteoclastic activity than osteoblastic activity and leads to osteoporosis. And with the estrogen, we tend to see lower levels of PTH and lower levels of 1,25 dihydroxy cholecalciferol as well with estrogen deficiency. So how does osteoporosis present? The osteoporosis has no clinical manifestation until there's a fracture. Pain occurs in 30 to 50% of the patients only. And many times as I see a patient in my clinical practice who's been seen by someone for body aches and pains, and I see these patients being put on osteoporosis treatment, I personally think that is not the right approach, and we need to go through proper diagnostic testing before we can diagnose osteoporosis and before we can put these patients on any treatment for that. So we'll come to that part as well. So osteoporosis most of the time has no clinical manifestation, and the fracture is the first clinical manifestation in these patients. Vertebral fractures are most common. They are diagnosed as an incidental finding on chest or abdominal x-rays. Usually the clinical manifestations of symptomatic vertebral fracture is height loss or pain. Hip fracture, distal radius fractures, we see that. And how do we diagnose osteoporosis? If someone has, if a patient has a low impact fracture, means a force which should not normally have caused fracture, and patient gets fractured from that, that obviously that puts that patient in a category where we can say, okay, patient has osteoporotic or weak bones. Our patient has fragility fracture. Just patient falls from a standing height and breaks a bone. That means this patient has underlying fracture, regardless of DEXA scan mineral density. So that's one way of seeing if patient has a fragility fracture, low impact fracture, possibly has osteoporosis, would need treatment and workup. But if a patient if the patient does not have any of those fragility fractures, so how do we tell if this patient has osteoporosis? Well, the DEXA scan is the way to go in these patients, dual energy X-ray absorptiometry. DEXA is the most widely used method for measuring bone mineral density. It gives precise measurements at clinically relevant skeletal sites. The major disadvantage of DEXA are that the machine is large, expensive, and it uses ionizing radiation, even though at a very low dose. And there's a variability of reading from one machine to other machine, and it is operator dependent as well. So the skeletal site for DEXA scan, which we measure the bone mineral density at, is the hip and spine. And not in old age, we see osteophytes in the spine. So sometimes there could be a false negative in terms of bone mineral density at spine because of excessive osteophytes in elderly patient. So hip, the DEXA of the hip is generally regarded as a best site for diagnosis of osteoporosis. And lumbar spine is considered the best skeletal site for monitoring the response to therapy. In the presence of degenerative changes of spine, BMD can be monitored at another skeletal site such as hip or radius also. So in the absence of fragility fracture, if the DEXA scan has a T-score of -2.5 based on WHO definition, that's what we call as osteoporosis. So either the patient with osteoporosis is only two criteria. If the patient has a fragility or low impact fracture, or if the T-score on DEXA scan is less than -2.5, -2.5 or less than that, that is osteoporosis. So here's a table for the T-score from WHO. The normal is should be more than one, more than -1. Between -1 and -2.5 is osteopenia, and 2.5 or less than that is osteoporosis. And then there's another category which is severe osteoporosis. Severe osteoporosis is bone mineral density of 2.5 or less than that, along with the fragility fracture. That is severe osteoporosis. Now, International Society of Clinical Densitometry criteria for postmenopausal and men more than 50 years, they follow the WHO criteria. But for the premenopausal men and, for the premenopausal women and men less than 50 years of age, the ISCD advises that WHO criteria not be used in this age group because the relationship between BMD and fracture risk is not the same in younger men. So in younger group of patients, it's preferable in those patients who use the Z-score. Z-score is the comparison of bone mineral density of a patient with the age-matched individual within the same age group. So Z-score should be used instead of T-scores in younger patients. So the next question is, who should be screened for osteoporosis? The goal of osteoporosis screening is to identify persons at increased risk of sustaining a low trauma fracture who would benefit from intervention to minimize that risk. So screening for fracture risk involves risk factors and measurements of bone mineral density. How many risk factors patient has and what is the BMD of that patient. Risk factor recommendation is to assess risk factors for fractures in all adults, especially the postmenopausal women and men over 50 years of age, and in any individual who experiences a fragility or low trauma fracture. And validated risk factors that are independent of BMD. They are race and ethnicity of that subject. So these are the clinical risk factors for fractures: advancing age, previous history of fractures, glucocorticoid treatment, parental history of hip fractures, low body weight, current cigarette smoking, excessive alcohol consumption, rheumatoid arthritis, and then there are conditions which can cause secondary osteoporosis if patient has any of those, like hypogonadism or premature menarche, all celiac disease or other malabsorption syndromes. So how do we calculate this risk factor assessment based on their risks in a patient? So for that purpose, the FRAX was developed to estimate 10-year possibility of fracture at the hip, spine, shoulder, or wrist for an untreated woman or man. So it uses clinical risk factors for fractures, which I just mentioned earlier, with or without BMD. So the best part of FRAX is if you don't have access to DEXA scan, you can still tell the risk for bone fracture in that patient. And if you have DEXA scan, you can put those numbers in and you can still, it's still valid. So it can be used both with BMD or without BMD. So the clinical diagnosis of osteoporosis may be made when the fracture risk assessment tool 10-year possibility of major osteoporotic fracture is more than 20%, or the 10-year probability of hip fracture is more than 3%. Usually I tend to stick with the second part, the 10-year probability of hip fracture more than 3%. If my FRAX calculator is going to tell me that, that means that patient is at higher risk for fractures and needs to be treated as well. So how FRAX is helpful in our patients. FRAX is helpful, especially in setup where we do not have the DEXA scans readily available, and not everyone has the financial means to get DEXA scan. In those patients, we can do the FRAX scoring without DEXA scan, and if the scoring suggests that 10-year probability of hip fracture is more than 3%, these patients can go on osteoporotic treatment. So this is the calculator. You can download this from net easily. So all you need to do is put in patient's information, all those risk factors which I previously mentioned. So enter those, and then it calculates the risk of fracture in that patient. If patient's BMDs are available, that can be entered. But if you look at the 12 point, that's a femoral neck BMD. If that is available, great. If not, even that can be calculated without the BMD as well. So once you get the risk factor, and if risk factor is the 10-year probability of hip fracture, it tells you more than 3%, then that patient should be either sent for DEXA scan if you did not have, and if you had DEXA scan, then that patient should be treated. On the other hand, if the DEXA is not readily available and still 10-year risk comes out to be of hip fracture is more than 3%, these patients need to be treated. So who should get the DEXA scan? All women 65 years of age and older. Number 2, postmenopausal women younger than 65 years of age with clinical risk factors for fractures. Number 3, bone density screening is not routinely recommended for premenopausal women unless there is some underlying risk factors, like patient is on steroids, patient has premature menopause, then that's different. In patients with history of fragility fracture, or in patients where we suspect there's where we know there's a secondary cause for osteoporosis, yes, those patients also need BMD tested with the help of DEXA scan. So these are the different secondary causes we went through earlier as well. So DEXA scan has to be done in a select group of patients, like I said in the previous slide. What about men? There's no universal agreement about BMD testing in asymptomatic adult men. The Canadian Osteoporotic Society recommends BMP testing for all men older than 65 years of age, but most of other experts, they do not believe in that unless there are some underlying risk factors in these patients, like clinical manifestation of low bone mass incidentally on x-rays, history of low trauma fracture, loss of more than 1.5 inch in height, are those with risk factors for fractures with secondary causes for osteoporosis. In those men, yes, by all means, DEXA should be done. Now, prevention of osteoporosis. How do we prevent osteoporosis? Obviously, by helping the patient to achieve the peak bone mass, that's one way of doing it. And secondly, to minimize trying to minimize the bone loss. So how can that be done? So minimizing the bone loss. So in first step is, of course, the foundation step, which is the prevention and treatment of osteoporosis is based on lifestyle changes in nutrition. We should not be using, we should be using foods with this with a good amount of calcium in it. The normal daily requirement of calcium is about 1,000. We should have enough vitamin D on board in our patients. So healthy nutrition lays the foundation of strong bones. Physical activity, more physical activity, the stronger the bones are. We need to prevent the falls in our patients, especially the elderly and frail patients. So that plays a role into the preventive aspect. The second step is addressing drugs and diseases associated with bone loss and osteoporosis. So we should always periodically examine patients' medications to make sure that patient is not on any medication which may be decreasing the bone mass of the patient. And of course, then after that, the pharmacological interventions that come in trying to minimize the bone loss. And we will go to that in detail. A healthy lifestyle includes a good physical activity, 30 minutes on most days of the week, adequate nutrition with protein, calcium, and vitamin D, cigarette smoking cessation should be done, no alcohol intake or minimal alcohol intake, fall prevention, and now the calcium, the postmenopausal woman should consume about 800 units of vitamin D and 1200 milligram of elemental calcium, and premenopausal women or men, 1000 milligram of calcium usually is needed in these patients. So pharmacological therapy for postmenopausal women and men with age more than 50 years is recommended if there's a history of fragility fracture with osteoporosis based on mineral density with a T-score less than or equal to 2.5, and pharmacological therapy for treatment for high-risk patient T-score between -1 and 2.5 with 10 years probability of hip fracture or combined major osteoporotic fracture more than 3% or more than 20% respectively. So these are the three group of patients where we want pharmacological therapy: history of fragility fracture, osteoporosis based on DEXA scan, or in those patients where based on their FRAX scoring, their risk for fracture is high, like I said in previous slides. So these three group of the patients where we want pharmacologic therapy to be given. What are the choices of drugs in the absence of the head-to-head trials comparing one drug to the other? Choice of therapy should be based on efficacy, safety, cost, convenience, and other patient-related factors. But remember, all these patients, before we start any pharmacological therapy for osteoporosis, these patients need to have normal serum calcium and normal 25 hydroxy vitamin D levels. So these are the substrates which are very important, facilitators which are very important in formation of the bone. So the initial therapy, the first-line therapy, I will call for most postmenopausal women with osteoporosis, oral bisphosphonates are the first-line therapy. Oral bisphosphonates are preferred as initial therapy because of their efficacy, favorable cost, and availability of long-term safety data. Not every patient needs to be treated with IV bisphosphonates. The preference should always be given to oral bisphosphonates unless there's a reason not to use oral bisphosphonates. In that case, we can consider going to IV bisphosphonates, and we will talk about that in coming slides. Now, briefly, a few more slides, and then I'll finish my presentation. I would like to just to run through these agents quickly, that there are anti-resorptive agents which help to decrease the resorption of the bone when it comes to osteoporosis prevention. And then there's anabolic agents which stimulate the bone formation. So bisphosphonate are anti-resorptive. Alendronate, risedronate, ibandronate, and zoledronic acid, you all are well aware of that. And denosumab, which is human monoclonal antibody that binds the cytokine rankle. That's an essential factor in initiating bone turnover. So it blocks that rankle pathway, the way what I described in earlier slides. So the rankle inhibition blocks osteoclast maturation, function, and survival. Thus, it reduces the bone resorption. So bisphosphonate and denosumab are anti-resorptive agent. PTH, teriparatide, and abelaparatide, PTHRP, they are anabolic agents. And remember, I've been talking about PTH as factors which lead to increased resorption. But when these hormones are given in a pulsatile fashion, they have osteoblastic activity within the bone. So stimulate the osteoblast there. So PTH and PTHRP, both teriparatide and abelaparatide, they are anabolic. They are osteoblastic medications for osteoporosis. Estrogens and progesterone, they also have some osteoblastic activity, but these increase the risk for breast cancer, stroke, venous thromboembolism, and so that's why we prefer not to use these drugs long-term in females. Other agents are selective estrogen receptor modulators. Tamoxifen and raloxifene are prime example of that. There's SERMs, they block estrogen action in the breast cells and activate estrogen action in other cells such as bone and uterine cells. So they are helpful, can be used for a longer time. And then there's another newer agent, which is anti-sclerostin, rosozumab. This is a human monoclonal antibody against sclerostin. It prevents sclerostin from exerting its inhibitory effect and thus activates the VNT signaling and causes increased bone formation in subjects. Contraindications for bisphosphonates, who should not be given oral bisphosphonates: the one with esophageal disorders, inability to follow the dosing requirements, and patients with a CKD with GFR less than 10. In those patients, oral bisphosphonates should be avoided. And sometimes even patients who had some surgical procedures like Roux-en-Y, gastric bypass, oral bisphosphonates are not the best options in these patients. For patients with GI disease, that's where the IV bisphosphonates come in. IV bisphosphonates, zoledronic acid has demonstrated to reduce vertebral and hip fractures. But like I said, IV should not be the first modality to be used in patients with osteoporosis. We should always resort to PO unless there's a reason for to use IV. So just to sum up all these things, the first line, we prefer oral bisphosphonates or IV bisphosphonates if patient is intolerant or if there's any contraindication not to use oral bisphosphonates. The second line drug in these patients, we use teriparatide or PTHRP in these patients. And for patients with severe osteoporosis, remember I defined severe osteoporosis earlier, someone who has BMD of less than 2.5 or less than that, minus 2.5 or less than that. In those patients, yes, and then plus there's a fragility fracture. That's a severe osteoporosis. In those patients, parathyroid hormone can be started as a first-line therapy in these patients. Third line, or after, if the first line, second line for some reason cannot be used, then third line is denosumab is a reasonable option, particularly in patients with a renal impairment. And obviously the emerging data has raised concern about increased risk of vertebral fracture after discontinuation of denosumab. Thus, the need for definitive treatment should be addressed with patients before this denosumab is initiated, meaning thereby you start this drug on a patient, you need to continue for the very long term on those patients because the newer data has shown some risk for increased risk for vertebral fracture once you discontinue denosumab in these patients. Fourth line, raloxifene can be used. Fifth line, well, not anymore. Estrogen, progestin agents, we do not use these days in our patients. So this is a slide for severe osteoporosis, which I already have defined a few times earlier. In these patients, anabolic hormones, teriparatide or abelaparatide or romosumab, they are the first line agents in these patients to be used instead of bisphosphonates. How do you measure response to therapy? DEXA is a good tool to do that. For patients starting on therapy, a follow-up DEXA and hip scan after 2 years, and then every 2 years thereafter with more frequent testing in certain clinical situations. So once you start these patients on this therapy, at least I would say give a couple of years before you go for next DEXA scan on this patient. If patients' BMD is not improving, being on first line therapy, then you switch to the second line therapy on those patients. Usually we say when the decline, when the bone mineral density stays stable, that is fine. But when the bone mineral density is drops by more than 5% in 2 years DEXA scan in a patient, then we consider switching from first line to second line therapy on these patients, or changing the therapy on these patients. Now, for how long these patients should be treated, well, that really depends the risk of the patient. If patients are low risk for fractures, maybe 5 years, 3 to 5 years is a good time frame. If patients are high risk for fracture, maybe the patient needs to be treated for about 5 to 10 years time. So that has to be individualized in every case as far as the therapy goes. But remember, the PTH or PTH-RP analogs, teriparatide, etc., they should be limited to about 18 to 24 months, so less than 2 years, because there's a possibility of increased risk for osteosarcoma of the bone in these patients when these drugs are used for the very long term. Denosumab, for the reasons I mentioned earlier, that usually needs very long-term treatment, maybe for 10 years or so, because if you stop it too early, these patients, the data has shown, tend to have increased risk for vertebral fractures as well. I think if I don't mention osteonecrosis of the jaw, it will be unfair to my presentation, because with certain agents in certain conditions, we have seen a risk of osteonecrosis of the jaw, especially in patients with breast carcinoma, with multiple myeloma, bisphosphonates for the long-term treatment, or denosumab, which is a rankle antagonist for the long-term treatment. It has caused increased incidence of osteonecrosis of the jaw. And for that purpose, I think the drug-free holiday sometimes needs to be introduced in these patients. If the patients are on these medications, maybe after 3 years, they need to go on a drug-free holiday for a few months and then go back to those the same agent if there's a risk for osteonecrosis of the jaw in these patients. And these are the very general principles. Like I said, we want to give treatment, but at the same time, we want to emphasize on other factors so that the bones can stay healthy. Look at the medications patients are using, make sure and try to stop whatever can be stopped in patients' medicine regimen. If any of those agents are causing, any of those agents can cause bone loss in patients. Patients should do weight-bearing exercises regularly, should avoid smoking, excessive alcohol, and preventive measures to prevent falls in these patients is very important as well. So with this, I think we have covered this most parts of the osteoporosis. This was the last slide, which is, I believe, is the duplication of the earlier stuff where we said the first line, second line, third line, and fourth line agents for osteoporosis. So we have gone through that. And with this, I will thank you all for your patient listening. And thank you for the organizers of the RheumaCon 2021 to invite me for this very important talk. I'm grateful. Thank you.